Welcome back. So today I'll be discussing an approach to peripheral edema, part 4.2. That is an approach to thrombotic microangiopathies. So we've now discussed, peripheral edema due to oliguric renal dysfunction. For example, due to glomerulonephritis. And today we'll complete the glomerular disorders by talking about thrombotic microangiopathies. Now, as we've already discussed, glomerulonephritis, microangiopathic hemolytic anemia, which is the clinical presentation of that correlates with the histology of thrombotic microangiopathy. Both of them have a common feature, that is they have increased RBCs, WBCs, and subnephrotic proteinuria in the urine routine. RBCs are dysmorphic, and now occasionally, thrombotic microangiopathies can also present with a bland hyaline cast, which is a less common pattern, which is the more common pattern, but obviously is less specific. Okay, so these are the two, this is where we are, and this is what we will be discussing today. Now, okay, so moving on. As we've already discussed with the glomerulonephritis, we've seen how routine blood investigations can help you reach etiological diagnosis. Similarly, we've also discussed that a very significant decrease in platelet count, but relatively normal serum creatinine indicates the presence of thrombotic thrombocytopenic purpura, and a slight reduction in platelet count, but very significant renal dysfunction or proteinuria indicates APLA. Okay, antiphospholipid antibody syndrome. So we'll elucidate, this a bit further and get into the, the weeds of it. And okay, so the mechanisms of injury are quite interesting. So what happens is, the first thing that we start with is an antibody that gets deposited subendothelially. Now this is exactly what happened with our immune-mediated glomerulonephritis. And similar to that, an antibody is just getting deposited subendothelially will activate complement, resulting endothelial activation, which results in platelet activation, and activation of the endothelium also results in activation of the coagulation cascade, resulting in a microvascular thrombosis. But see here, because of complement activation, some neutrophils will come in, and because neutrophils will come in, this will be an inflammatory infiltrate on histopathology. So technically, yeah, antibody mediated immune endothelial damage would technically also be a microangiopathic hemolytic anemia, but there is inflammation there, so we call that glomerulonephritis. Now, there is an exception to this rule that when you have microangiopathic hemolytic anemia as a component of antiphospholipid antibody syndrome. So, in that situation, the antibody is actually targeted against the cell membrane of the endothelial cell, and then secondarily causes activation of pathways within the endothelial cell, resulting in endothelial activation rather than classical complement activation and secondary immune damage. So we'll discuss that with in detail when we discuss antiphospholipid antibody syndrome. However, here we're going to discuss some other mechanisms. Okay, so one is, the first mechanism is antibody mediated endothelial damage. The second mechanism is activation of the complement alternate complement cascade. Now the alternate complement path cascade is also called the tick over cascade. This is because, like the the hands of a clock, it keeps ticking over, it's always active. So why is it always active? Because your complement or your C3 complement protein, when it is in water, so we call it C3H2O. Okay, that is this protein, when in water, it is constitutively active and continues to activate factor B, and that is lyse factor B. And it converts factor B into factor BA and BB. Now, once factor A and BA and BB have been formed, fact C3H2O and BB combine together to produce a combined dimer called the C3H2O BB complex. Okay, and the C3H2O BB complex in turn has an interesting effect. It has an increased ability to lyse again C3, and this is not C3 that is water soluble, that is C3, just C3 without being solubilized in water. So again, it leaves C3 into producing C3A and C3B. So C3 then gets converted into C3A and C3B. Now, obviously C3A is what is involved in bringing in neutrophils and etc. Just like C5A. Okay, but C3B is a membrane bound component. So this membrane bound C3B then binds to further C3H2O and BB. So this entire complex catalyzes the formation of C3B and then binds to it. Okay, it binds to C3B, forming this complex that is called the C3H2O BB C3B complex. So that would be C3H2O BB C3 complex, or rather C3B complex. Okay, and this is a, because C3B is membrane bound, this is also a membrane bound complex. Okay, now once this happens, once you got your membrane bound C3H2O BB C3B complex, that starts to hydrolyze C5, that is complement factor 5, to produce C5A, and additionally also produce C5B. Okay, now this C3H2O-BB C3B complex is what we call the alternate complement C5 convertase. Okay, and this naturally obviously causes your C5A production, which can bring in neutrophils, but in this particular situation there is a slight difference here. So this C5B component that is there goes and binds to catalyzes further reactions and binds to C6, C7, C8, C9 to produce something known as the membrane attack complex. Okay, so as the name would suggest, it attacks membranes and it gets inserted into the cell membrane of endothelial cells. Okay, so that is this. This is the membrane attack complex. Now, once it does that, it allows for calcium entry into the cytoplasm of the endothelial cell, and that causes endothelial activation. Okay, so as you can see, if this C alternate complement pathway, this entire pathway is not regulated, this would keep damaging cell membranes in the cell within the that are present over the cells that line your endothelial or your vascular structures permanently. Now, so why does that not happen? That is because we have got an inhibitor of this pathway that is known as factor I. And factor I is helped by another factor called factor H. So factor H plus I together actually inhibit this pathway. And how do they inhibit it? That is by degrading C3b. Okay, and we'll see C3b has got multiple, we've discussed it in briefly previously. C3b gets degraded into C3d, C3dg. Okay, and we'll get to that later. Okay, and in this process, the formation of MAC is shut down because we no longer form the alternate complement C5 convertase. So this is so how is this done in under physiological conditions? So basically, factor I and H are always present on all cell membranes that are produced within the human body. So because of that, that is prevented. Now, fact I is actually a protein that is attached to cell membranes using a very specific mechanism. Okay, and that mechanism is, it is bound to ionosytol phosphate. Okay, and there is a disease called your paroxysmal nocturnal hemoglobinuria. Okay, and that in that you have a selection of a clone within the bone marrow that does not express proteins that are phosphatidyl inositol bound. um, why and how, we'll get to it later. So as a result, things like factor I are not expressed on cell membranes, and that results in excessive alternate complement activation. Okay, so PNH is also something that has got excessive alternate complement activation, but because of that is because of a hematological stem cell problem in the bone marrow. We'll get to it later. Okay, now there are other ways of activating complement as well. So this was the that we're not going to go to. So this was the complement mediated pathway. Okay, now see, technically the same thing can also happen if you've got a toxin that is getting inserted into the cell membrane and producing a pore. Okay, so that therefore I combine these two mechanisms of injury into one, that is the complement or toxin mediated endothelial damage mechanism. Okay, so we have antibody mediated endothelial damage, and then we have complementary toxic mediated endothelial damage. Okay, then we have something called von Willebrand factor. Now, von Willebrand factor is synthesized and secreted into the blood by the liver by hepatocytes, and it is synthesized as a polymer. So, all of these diamond-shaped yellow structures are single von Willebrand factor monomers that have been that are produced bound to each other, and in blood it is it is hydrolyzed and to produce von Willebrand factor monomers by a protein called ADAMTS13. Okay, so these are the monomers. Now we'll discuss this again in von Willebrand factor disease, von Willebrand disease rather. Both of these, that is polymeric von Willebrand factor and monomeric von Willebrand factor, have their own functions, and they are very important functions. Now monomeric von Willebrand factor binds to factor 8 and ensures that its not T half is normal, that is 6 to 8 hours. Okay, if it is not bound to factor 8, then the factor 8 T half shortens significantly to 1 to 2 hours, and therefore the serum levels of factor 8 fall down, resulting in something known as autosomal hemophilia. Now, on the other hand, polymeric von Willebrand factor should be maintained at a relatively normal range. Now, if you inhibit your ADAM TS13, what ends up happening is there is an increase in the number of polymeric von Willebrand factor in blood, and because of that, what you end up having is platelet activation, because von Willebrand factor can bind to platelet directly via receptor. Okay, and results in platelet activation. Now, see, importantly, here platelet activation is occurring as the primary mechanism with some secondary endothelial damage, because platelet activation causes coagulation cascade activation, which will secondarily damage your endothelium. But endothelial damage is very minimal. It is primarily platelet activation, and therefore, if this is the mechanism by which the process is happening, we will have a very significant fall in the platelet count, but a relatively spared microvasculature. So there will be very minimal thrombosis. So therefore, because we are talking about the kidney, glomerular thrombosis will be minimum. Therefore, the fall in GFR will be minimal. Therefore, uh, the increase in creatinine will be minimum. So that's what we find with our cases of thrombotic thrombocytopenic purpura. Whereas on the other hand, if you have APLA, okay, the process is starting with endothelial damage. So because it is starting with endothelial damage, there's a lot of thrombosis, and in that thrombosis, platelets are getting used up. But again, that thrombosis is microvascular. It is happening within a particular vascular bed in this particular scenario. So because of that, the plate reduction in platelet count actually happens much later. It is a secondary process. Okay, so you get some reduction in platelet count, but most importantly, it's not very very low, whereas the reduction in serum creatinine is very very high. Okay, so this is something that you can use clinically to differentiate between these two mechanisms. Now, so that is a second mechanism of injury. Now the third mechanism is just a deficiency of this ADAM TS13. That is, the person does not produce enough ADAM TS13, or whatever ADAM TS13 the person produces is not enzymatically capable of degrading polymeric von Willebrand factor into monomeric von Willebrand factor. Okay. Then finally, there is an interesting thing. You can have in during pneumococcal infections, and sorry, I mean influenza infections, the enzyme neuraminidase, which is produced by the influenza virus, can expose what is known as the Thomas Friderichsen antigen on the surface of the endothelium. Okay, and see, the Thomas Friderichsen antigen is not something that is normally expressed at all in in cell membranes that are all of endothelial cells in normal people. We actually have IgM, constitutively express IgM antibody against this Thomas Friedrich antigen, and because of that, this IgM goes and then binds to the Thomas Fredrickson antigen and then causes complement activation. Okay, the antibody causes classical complement activation. So in that process, it's very similar to APLA. Okay, and therefore it resembles hemolytic uremic syndrome. So as you can see, uh, these two mechanisms resemble each other in that there is significant microvascular thrombosis, but only some thrombocytopenia, and these two mechanisms resemble each other clinically because there is significant fall in platelet count, but very minimal, or significantly less microvascular thrombosis, and therefore less renal dysfunction. Now, microvascular thrombosis in non-renal microvasculature is slightly more, and therefore the clinical, the distribution of the disease is more extensive when the injury is when it is due to ADAM TS13 dysfunction, either acquired or congenital. But so therefore, thrombotic thrombocytopenic purpura, as we'll see, has got a classic pentad, but otherwise the renal dysfunction is very minimal. Okay, so we'll call this mechanism 1, we'll call this mechanism 2, and we'll call ADAMTS13 deficiency mechanism 3 and neuraminidase expression by an infective agent as mechanism 4. Okay. Now, as you can obviously see, this is mechanism 1. Okay, that is alternate complement activation, and this is happening because there are genetic mutations resulting in decrease in the expression of the proteins that regulate the alternate complement pathway. Because as we've just discussed, the alternate complement pathway is constitutively active. That is why it is called the takeover pathway. And if it is not inhibited, it keeps damaging endothelial cells in an in a runaway reaction. Now, similar to this, mechanistically at least, if there is a toxin that can perform the same function as the as the membrane attack complex, that also will have the same effect. Okay, so that is this. Now, in case of mechanism 2, this is what we have. We have a activation of the we have a defect in the activity of ADAMTS13 enzyme. Okay, so this is I've highlighted it, and this results in increase in the polymeric von Willebrand factor levels. That results in platelet utilization, and then secondarily results in some kind of activation of the coagulation cascade. This goes in this way as well, and then secondary endothelial activation, but not very significant. Okay, very minimally this happens. That's why I've not drawn the diagram in that direction in order to avoid confusion. Now, so this is our mechanism number 2 and mechanism number 3. Okay, and mechanism number 4 I've not drawn in the diagram to keep the diagram relatively clutter free, but it is due to similar to an antibody mediated endothelial damage. Okay, okay. Now let's just plot all these mechanisms on a table. Okay, so this is mechanism 1, this is mechanism 2 and 3, and then mechanism 4. Okay, now there are some clinical entities that we have named. One is hemolytic uremic syndrome. What is hemolytic uremic syndrome? In hemolytic uremic syndrome, by definition, the problem is with the alternate complement pathway or due to a toxin mediated damage. Now, in classic your hemolytic uremic syndrome, what happens is that the patient has a antecedent history of having a diarrheal episode, often a dysentery episode, okay, during which actually the infection was caused by your Shiga toxin secreting and in E. coli, that is S or Shiga toxicogenic E. coli STEC, or enterohemorrhagic E. coli HEEC, EHEC rather, okay, of very specific serotypes. That is, these are factual questions, so you need to know them. Specifically, O157H7, okay, but also to a lesser extent, O157, O111, your O26, H11, okay, your O145 and H28, as well as O106, H4. Okay, and so again, these are these are very factual questions, and honestly, there's not really any need to remember them. But if you feel the need, please go ahead and remember it. Okay. Now, either way, what ends up happening is that this infective organism produces Shiga toxin 1 and Shiga toxin 2, and that binds to glycolipid sulfate GB3 on the surface of endothelial cells. Okay. So because of this, what ends up happening is that the catalytic portion of the toxin is inserted into the endothelial cell, and that induces the expression of interleukin 10, macrophage chemoattractive protein 1, SPF1, and other chemokines, resulting in endothelial damage. Okay, so this is your classical hemolytic uremic syndrome. This is the exact pathogenesis of what is happening. Okay, now, because of that, there is endothelial activation and secondary platelet utilization. But see, the process is primarily endothelial damage. So you get a lot of microvascular thrombosis with minimal reduction in platelet count. And whatever reduction you get in platelet count, it happens at the beginning of the disease. Often by the time the patient has come to you, the platelet count has recovered. In case of Adam TS13, so similarly, hemolytic uremic syndrome can also be caused by streptococcal pneumoniae infections, and then we call this strep pneumoniae, HUS. Obviously, influenza virus also produces a neuraminidase, so both organisms produce different neuraminidase enzymes, and both can cause this problem. So this is with a lung infection, that is a community-acquired pneumonia. Now, in case of atypical hemolytic syndrome, what we have is actually two very interesting mechanisms. One is we either have mutations in those regulatory pathways that we were discussing regarding the alternate complement pathway. Another interesting thing that can happen is you can have mutations in complement factor related proteins R1, R3, and R5. Now, what does this happen? Basically, what ends up happening is that these complement factor H related peptides are actually structurally very similar to complement factor H. Okay, and they are the ones that are expressed in the thymus. So when your T cells are developing in the thymus, they are not exposed directly just to complement factor H. They are also shown complement factor H related peptides 1, 3, and 5. Now those cells that react to these complement factor H related peptides 1, 3, and 5 are then removed, which is called central tolerance, are removed or killed off, and as a result in the periphery you don't really have cells that are T cells that are capable of recognizing complement factor H related peptides or factor H. Now, if you have a loss of function mutation in complement factor H related peptide 1, 2, 3, and 5, it is then obviously not going to be, its structure is going to change, and therefore it is not expressed in its normal structure in the thymus. So, as a result, within the thymus, the normal negative, removal, or the normal central tolerance that would have removed these self-reactive T cells that recognize complement factor H R1, 3, and 5 does not happen, and because of that in the periphery you end up getting you end up getting T cells that are reactive to complement factor H related peptides as well as complement factor H because of the structural similarity between the two proteins, and these then later in adult life end up producing antibody, helping B cells produce antibodies against complement factor H. Okay, and those antibodies then interfere with the functioning of normal complement factor H, and that, as we've seen, is what we get with is what it causes atypical hemolytic uremic syndrome. Now, importantly, and this is very important, here an antibody is the cause of the damage to the atypical hemolytic uremic syndrome. So in that situation, removal of the antibody would be useful. Okay, that would be our treatment approach. Whereas in this situation, what we have is we have a constitutive genetic defect that is causing antibody alternate complement activation. So actually, we need to inhibit the alternate complement pathway itself. So we do that with an antibody called eculizumab. Okay, I'm not going to go into the details of that right now. But see, here eculizumab will be effective. Here, removal of antibody would be effective. Okay. Now, coming to your thrombotic thrombocytopenic purpura. So here the problem is there is a antibody, but this time the antibody is targeting ADAMTS13. Okay, the enzyme ADAMTS13 is inactive, and therefore your polymeric von Willebrand factor is not getting converted into monomeric von Willebrand factor. Alternatively, you have genetic deficiency. So there is a genetic ADAMTS13 deficiency, because of which again polymeric von Willebrand factor levels rise, and that then causes platelet activation but very minimal microvascular thrombosis. So because of that, you end up actually having a significant thrombocytopenia but not very significant end organ damage in the form of azotemia or increase in serum creatinine. Now, finally, we have something known as the Upshaw-Schulman syndrome. Now, Upshaw-Schulman syndrome is also called congenital TTP. Okay, so this is basically a genetic deficiency in your expression of ADAMTS13. It's the same as this. Okay, there's no difference. I've just shown it separately because I wanted to tell you the name of the diseases. Okay, and so that's our three entities that come under microangiopathic hemolytic anemia. That is hemolytic uremic syndrome, atypical hemolytic uremic syndrome, and thrombotic thrombocytopenic purpura. Okay, thrombotic thrombocytopenic purpura has prominent thrombocytopenia, very minimal or relatively minimal azotemia, whereas the other two have significant azotemia with less prominent thrombocytopenia. Thrombotic thrombocytopenic purpura, which is immune mediated, is also called immune thrombotic thrombocytopenic purpura. Okay, and sometimes an antibody can cause deficiency rather than just inhibiting ADAMTS13. That's why I've shown it here as a separate thing. Now, atypical HUS is now more commonly called complement mediated HUS, and that is what they call it. Okay. Okay, and again, Upshaw-Schulman syndrome specifically refers to congenital TTP, which is CTTP. So these are the terms that have been used in the ACH, your International Society of Thrombosis ICTH, that is guidelines. So that's why I've highlighted them here. But in Harrison, they've stuck with the old terms. Okay. Now, we also have something called drug-induced microangiopathic hemolytic anemia. Now, this is actually it. It there the all three mechanisms, at least the first three mechanisms, can be can occur due to drugs, and okay, so all three mechanisms or all four mechanisms can occur due to drugs, and in that situation, a drug that produces antibodies against ADAM-TS13 uh, would be, not be related to the dose of the drug. So this happens classically with, quinine. It also happens with ticlopidin, and in case of ticlopidin, the antibodies are only anti-ADAM-TS13, but in case of quinine, the antibodies are against a host of platelet um, uh, cell surface cell surface proteins, which results in platelet activation without inhibiting ADAM-TS13. So that could be against glycoprotein 1b95, that is silane loses factor receptor, glycoprotein 2b3a, which is the fibrinogen receptor. It could be against granulocytes, lymphocytes, and anti-endothelial cells directly. So with quinine, the mechanisms are slightly disparate and varied. Okay. Now the second thing is you could have a toxin-mediated endothelial damage. So this happens classically with chemotherapy, particularly that happens with your mitomycin C and gemcitabine. Now it also happens more commonly in my situation when I give patients calcineurin inhibitors, that is your cyclosporin or tacrolimus. We don't typically use sirolimus. And very importantly, it happens with proteasome inhibitors that we use in treatment of multiple myeloma, that is bortezomib and your calfilzomib, etc., exizomib, etc. Now, the important thing is that again, this, if you recall, the one of the side effects of proteasome inhibitors is a deep vein thrombosis. And why would that be? Because there is endothelial activation happening there. Now, coming to the treatment, obviously, so the treatment is not actually per se dependent on the name of the disease that you have given to the disease. It is dependent on the mechanism. So that is why it is in this sequence that I have written treatment. So I don't normally discuss treatment at this stage, but the mechanisms here, give you an opportunity to understand the treatment options very easily. So obviously, if it's an antibody-mediated thing, you first remove the antibodies mechanically with plasmapheresis, and then you give rituximab, so the cells that are producing the antibody, at least to some extent, can be reduced. Okay. Then in case of complement mediated damage, if it is toxin mediated, you remove the toxin. That is, obviously the infection has already occurred. Importantly, antibiotic treatment in dysentery doesn't necessarily decrease the risk of toxin mediated damage, and it may in fact increase the risk. Okay. And then there is some doubt that giving antibiotics that decrease protein synthesis might be protective against your complement mediated endothelial damage, your toxin mediated endothelial damage in case of hemolytic uremic syndrome. But again, it's not been studied in proper randomized control trials, so it's better not to go into that right now. Okay, but what we can do is when it is complement mediated, we can inhibit the alternate complement pathway with eculizumab. Eculizumab is extremely expensive in India at least. Okay, then we have got Adam TS13 deficiency. So in that situation, we replace Adam TS13. Adam TS13 can be replaced by giving fresh frozen plasma. Okay. And in case of neuraminidase expression, that is a community-acquired pneumonia patient, we give washed out RBCs and we try to kill Streptococcus pneumoniae off by giving antibiotics appropriately. Okay, so we give washed RBCs, and these days the treatment options are pretty self-explanatory if you understand the mechanism. So it is important to talk about them. Now, the genetic mechanisms of atypical HUS are quite varied. One is, as we've discussed, you can develop antibodies, and I've discussed why that is. Okay, so you can have complement factor H related peptides 1, 3, and 5 that are not being expressed, and as a result of that, central tolerance fails, and you have had T cells that are that develop against complement factor H, and they help B cells that are anti-complement factor H reactive to produce antibodies that go and inhibit complement factor H. We can also have mutations in the regulatory peptide proteins that are part of the alternate complement pathway, which would be loss of function mutations, or you could have gain of function mutations that result in activation of the enzymes that of factors like complement factor C and complement factor B. Okay, so you got complement factor 3 and complement factor B gain of function mutation, then you got loss of function mutation in complement factor H and I. This is to be expected, and also two proteins that are involved in inhibiting the membrane attack complex itself. That is thrombomodulin and your MCP. Okay, now there are some clinical associations of these that have been mentioned. Okay. Uh, Now, H and I are the ones that have the worst renal prognosis. These patients often require renal transplantation, and even in the transplanted kidney, there is recurrence. Okay, as we discussed previously for C3GN. Now, MCP has got a slightly better renal prognosis. The risk of, uh, the risk of renal dysfunction is lower, and your thrombomodulin basically your what ends up happening is the thrombomodulin is a protein that like factor I and H catalyzes degradation of your factor C3b. So because of that you have excessive activation of the pathway. So this is very analogous to how complement factor H and I function. Okay. Now, how I remember this is that your uh, MCP can be remembered using the its actual the acronym is membrane cofactor protein. Okay, but I remember it as most commonly preserved renal function. Okay, so MCP. Okay, now with complement factor H, which is the most common defect, multiple families have been identified with complement factor H mutations. Around 70 such mutations have been found in the complement factor H gene, which are known to be pathogenic. The most common mutation is a missense mutation that affects the C terminal region, preventing binding to C3b and thus but not affecting the concentration of your complement factor H. So if you measure complement factor H level, they'll be normal, but functionally it cannot bind to C3b. Okay. Now, uh, yeah, we have very rare mutations that can result in a thrombotic microangiopathic phenotype that have been also described, and therefore you should know that is cobalamin C. Cobalamin is obviously cobalamin part of B12 enzyme, vitamin B12, and diglycerol kinase, which is part of subunit epsilon, which is part of obviously the glycolytic pathway. Okay, so both of these essentially indirectly result in reactive oxygen species development in endothelial cells and secondary endothelial cell activation. Okay, so this is endothelial activation not due to alternate complement mediated damage. But again, they're very rare. Now, acquired TTP can be caused by very specific systemic autoimmune rheumatic diseases, or it may occur in isolation. Okay, so basically, you have acquired TTP due to, as I've discussed, antibodies to ADAMTS13, but it can also occur due to antibodies to thrombospondin receptors and to plasminogen activator inhibitor. That is the protein that inhibits activated plasminogen activation. Okay. Uh, Okay, so that is what you have. And the incidence, at least as per one registry in the US, in Oklahoma, is 2.5 people per 10 raised to 6 population, 2.9 people per 10 raised to 6 population. And there is a, because it is an autoimmune response due to antibodies, there is a female predominance of 1 to 3. It is 9 times, at least in that registry, more likely to affect people who are, self-described as black, and the median age at presentation is around 40 years. So this is something that you need to understand, that age becomes very important in deciding whether the TTP is a genetic problem or is it due to an acquired problem. Okay. Now, mortality rates without treatment, that is, if you do not identify it, are 90%. Okay. Whereas with treatment, it decreases to 20%. And complications are basically microvascular occlusion, and which results in which is the primary cause for microvascular build or for cell death. Okay. Now, importantly, in that lieu, what is the pentad of your patients with thrombotic thrombocytopenia purpura? So mainly there is thrombocytopenia naturally, and then there is some microvascular occlusion. Now that thrombocytopenia is causing alternate complement is causing the endothelial activation, which causes fever. So there's thrombocytopenia and fever, which are quite prominent, and they are often the main presentations. In addition to that, there can be three organ involvements. That is you have renal involvement, but very minimal to very you know prolonged course of preservation of renal function will be there. But importantly, there is involvement of the central nervous system and of the cardiovascular system. So you get heart failure and you get focal deficits or diffuse focal neurological deficits, and that often gets confused with hypertension related hypertensive encephalopathy, and that creates a clinical confusion. But again, when there is very significant thrombocytopenia and some renal dysfunction, but not very significant renal dysfunction. Usually the cutoff taken is less than 2.6. Okay, so milligram per deciliter of creatinine. So in that situation, strongly suspect thrombotic thrombocytopenic purpura. And if that occurs at a younger age, that is less than 40 years, there is a possibility of it being genetic, but often patients have an acquired defect and the median age of presentation is 40 years. Okay, now so basically, summing up, in cases of microangiopathic hemolytic anemia, which are unlikely to be hemolytic uremic syndrome, that is, you don't have a antecedent history of diarrhea or dysentery. If the platelet count is if your platelet count is less than 30,000 and the serum creatinine is less than or equal to 2.26, that is, there is significant thrombocytopenia but not very significant azotemia, then it is TTP. Okay, so in that situation, we go ahead and we measure the serum ADAM-TS13 levels. Now there are some clinical issues with this. The test is often quite expensive. It costs about 33,000 rupees in India. Okay, so that can be a problem if you are working in a resource limited setting. Anyway, based on the values of ADAM-TS13 in blood, serum values of ADAM-TS13, it's an enzymatic assay, so we are assessing activity. If it is less than 10%, then your diagnosis it is TTP. Okay, if it is more than 20%, it is actually not likely to be TTP, and therefore you must think of an alternative microangiopathic hemolytic anemia. In 1 to 20% cases, if the activity is between 10 to 20%, then you have your intermediate cases. So in that situation, you either can treat for TTP or you can repeat the test. um, Again, monetary issues are to be taken into account. Now, if there is a family history of microangiopathic hemolytic anemia and renal dysfunction, and if it is possible, measure serum complement factor BB as well as factor C5 to 9, that is a membrane attack complex levels, and they are elevated. You are dealing with complement mediated or, as I discussed, atypical hemolytic uremic syndrome. In that situation, the only way to confirm it is through genetic testing, with a small caveat that if you have a complement factor HR1, 3, or 5 mutation, you may have anti-factor H antibodies in the blood. Okay, and this is problematic as the only test because complement factor H antibodies are also present in 44% of the general population. So there is a possibility of it being a false positive. Okay. Now, finally, if you have very significant renal dysfunction, significant azotemia, but not very significant thrombocytopenia. Okay, so the creatinine is more than 2.26 and platelet count has not fallen below 30,000, then you can start thinking about antiphospholipid antibody syndrome. Okay. Okay. Now, importantly, your 70% of cases of complement mediated hemolytic uremic syndrome, that is atypical uremic syndrome, are spontaneous or they are sporadic, that is there is no genetic history, and this is something that is very important to understand. Familial history or positive family history is often present in less than 10 in only a few patients, that's 30% of patients. And even if you have a family history of atypical hemolytic uremic syndrome, the penetrance in that one particular family is usually less than 10%. Okay, so a family history of renal dysfunction, or microangiopathic hemolytic anemia needs to be taken with a grain of salt. Okay, you cannot, because normally there is no family history when you are diagnosing atypical hemolytic uremic syndrome, and even if there is a person with atypical hemolytic uremic syndrome in the family of your patient, the penetrance of the disease in families is very low. So as a result, it is likely that it is an alternate cause also even in that patient. Okay. Now, the other thing that you need to understand is that your antiphospholipid antibody syndrome can occur sorry, rather, your complement-mediated hemolytic hemogenic syndrome can also occur concomitantly with SLE lupus nephritis. So again, now we've discussed C3J as occurring in lupus nephritis. We have discussed your microangiopathic hemolytic anemia occurring due to complement-mediated HUS in lupus nephritis. Okay, and we've also discussed that antibodies, ADAMTS13 antibodies can form in patients with SLE. Okay, so with SLE, there are so many mechanisms of causing of renal damage that often it becomes clinically difficult to decide exactly what is the cause. Okay, and sometimes there are multiple causes. So one needs to at least be aware of the causes in order to work up for them. Okay. Now, there are three specific clinical situations in which you get microangiopathic hemolytic anemia, and I don't typically deal with these situations, but they are important to know about. Okay, the first is you have patients with HELP syndrome. Okay, now HELP is obviously stands for H for hemolysis, E for elevated, L for liver enzymes, okay, and LDH, and L for low platelet counts. Okay, L for low and P for platelet counts. So the second situation is HIV associated or HIV/AIDS associated hemolytic uremic syndrome, and the final one is radiation related hemolytic uremic syndrome. It also occurs post hematopoietic stem cell transplant, but that is, hematologists are very aware of it, so we need not talk about that right now. Okay, now in case of HELP, what ends up happening is you got fetal mRNA. Okay, which is targeting soluble FLT1, that is your vascular soluble version of vascular endothelial growth factor receptor 1, and another protein called endoglin, which results in that mRNA getting into maternal blood and interfering with vascular endothelial growth factor binding to its receptor. Okay, and because of that interference, it ends up resulting in endothelial activation causing thrombotic microangiopathy. Okay. In case of HIV/AIDS, what ends up happening is you got an advanced infection. There is direct viral damage to the endothelium. The virus accumulates in the endothelium, causes endothelitis, or you may also have an opportunistic infection with CMV, and that causes thrombotic microangiopathy. In case of radiation, it is the radiation directly that is damaging endothelial cell DNA, resulting in thrombotic microangiopathy. Now, there are some very specific risk factors for help in patients with in patients with MAHA. One is pregnancy related pregnancy related risk factors like all your abnormal placentation. Okay, the second is obviously if the serum levels of your soluble FLT1 and endocrine are elevated, and mRNA targeting soluble FLT1 and endocrine are elevated, but obviously we don't test that clinically on a routine basis. Then finally we have a positive family history. Okay, now the incidence in any given routine pregnancy is actually quite low. It is only 0.2 to 0.9% of all pregnancies. But again, since we're not obstetricians, we will get referred cases that are very likely to have HELP syndrome. Okay, now in preeclampsia, that incidence increases to 1 in 10 or 1 in 5 patients with preeclampsia, with severe preeclampsia, very importantly. Okay, and however, you must understand that HELP can occur even in the absence of preeclampsia. So around 20% of HELP cases are without any preeclampsia. Okay, so preeclampsia, particularly severe preeclampsia, definitely increases the risk of HELP, but just the absence of preeclampsia does not rule out HELP. Now, importantly, when does it happen during pregnancy? So it happens when your fetal mRNA is being produced at the largest quantities and is most likely to enter into maternal circulation. So this happens, the fetal mRNA that is being produced against soluble FLT1 and endocrine is produced because there is placental insufficiency, and that placental insufficiency, vascular insufficiency, induces hypoxemic signaling in the cells of the fetus, and that is what results in mRNA production. Okay, so this will happen when the placenta is either abnormally inserted into the uterus, or when the placenta is very large, that is in the third trimester. Okay, now very importantly, around 10% cases do occur before 27 weeks of gestation, and around 30% of cases can occur post gestation, that is after delivery also. Okay, now, mortality rates are high, particularly if undiagnosed. They are 7.5% to around 34%. Okay. Now, importantly, MAHA can be the first clinical presentation of HIV/AIDS Okay, that may be the first thing that the patient is presenting with. And radiation, the dose is important. And wherever I discuss radiation, anywhere, the dose of radiation will become very important. So either whole body or local radiation of 4 to 5 gray is what is considered to be capable of causing microangiopathic hemolytic anemia. Okay, it rarely occurs, you know, with around recurs with radiation. It develops around 6 months after receiving the radiation. So if in a patient who's had radiation, received radiation, if the dose was too less or if it has occurred too early, you must rethink the cause. Okay, and again the presentation would be what? Azotemia with hypertension with proteinuria, that is to be expected. Okay, now there are two more considerations that we need to discuss. One is we need to discuss how when a person has HELP syndrome in pregnancy, how to differentiate that from other causes of microangiopathic hemolytic anemia in pregnancy. This is a routine reference cause, a reason for reference in medicine. Okay, so that we need to discuss this. So the first thing that we can discuss is the patient, has this ever been, because say HELP can only occur in pregnancy because it is being caused by fetal mRNA. Whereas TTP and atypical HOS or CM complement mediated HOS can occur prior to that. Okay. The second thing we look for is the presence of mutations. Third is serum ADAM-TS13 levels, and finally we look for any evidence of endothelial activation. So for that we look for serum antithrombin 3 levels, and we look for serum D-dimer levels. Okay, let's see what we find in its HELP syndrome. So HELP syndrome is always going to occur in pregnancy. That is a given. Okay, but second thing is HELP syndrome cases have, you incidentally find complement pathway mutations in 30 to 40% of cases. So just the presence of a complement factor pathway mutation does not mean that the patient does not help. Okay. Similarly, ADAM TS13 levels are usually slightly decreased in HELP syndrome, but as we've discussed, to diagnose TTP, it is usually less than 10%. Okay, antithrombin 3 levels are decreased because there is, as I've discussed, endothelial damage happening here. Okay, so the antithrombin 3 shield, anticoagulant shield is lost, and therefore serum levels are low. And D-dimer levels are increased because again there is microvascular, thrombosis. Now, with TTP and atypical HOS, you may have a history prior to the present pregnancy of microangiopathic hemolytic, and that is that's literal gold dust. Okay, if you have that, then you can confidently say that this is not HELP. This is related to TTP or complement mediated HOS. The other thing that is highly specific is if the ADAM TS13 levels are very very low. Okay, now in normal cases, we use a cutoff of 10%. In a pregnancy, it is decreased further to 5% because naturally in pregnancy, as such, the serum ADAM TS13 levels are low, as you've just seen. Okay. Obviously, TTP patients don't have complement mediated pathway defects. Now, again, TTP causes platelet activation and very minimal, endothelial activation. So, if you have a doubt between TTP and HELP, then measuring antithrombin 3 and D-dimer levels will be very useful because they will be normal. Okay. So, but usually, as I've just said, HELP and TTP are clinically can be differentiated if you can do ADAM TS13 levels, but often ADAM TS13 levels are quite expensive. So what we look for is any evidence of hemolytic anemia, microangiopathic hemolytic anemia prior to present pregnancy, or we look for the presence of normal serum antithrombin 3 and D-dimer levels. Now, in case of complement mediated HUS, the mutations are always present because that is the reason for the pathway problems, and ADAM TS13 levels are almost always normal. Okay. Uh, Again, there is endothelial activation happening. And so usually you will find an elevation in antithrombin 3 levels and D-dimer levels, but it may be low. But in case of HELP, it is always going to be the case. Okay. So this is a very important table to understand. This is directly from Harrison 22nd edition. Now, the thing is, HELP occurs in patients with severe preeclampsia, and so we have patients who have just severe preeclampsia, we have patients with HELP with severe preeclampsia, and we have patients who have just HELP. So how do you differentiate between the three? So for that, what we do is we look for inflammatory markers and we look at the ratio of serum LDH to serum AST. Now, why? Because your LDH and AST are released when there is hemolysis, but AST is released only, is predominantly released when there is, or a lot of AST is released when there is hepatic damage. And as we've seen, EL is elevated liver enzyme. So AST elevation occurs. So the ratio would be lower in patients with HELP. Okay. Now, in case of severe preeclampsia, there is inflammation going on. So inflammatory markers in blood like CRP, interleukin 6, interleukin 1 receptor antagonists are elevated. And because there is immune activation, there is an increase in the soluble HLA-DR levels. Okay. Now, in HELP, this is very, very highly elevated. And if there is a component of HELP, you will have say CRP levels that are going into the hundreds. Okay. Similarly, IL-6 levels will be very, very high. So what I find most useful clinically is, however, in patients with severe preeclampsia, you have got a ratio that is less than 13:1. In cases with severe with HELP, you have a ratio that is around 13:1. And in HELP, usually because there is so much hemolysis happening, you got an LDH elevation that is very, very high. So that is 29:1. Okay, so 30. Most people were getting pregnant around 30 years old, is how I remember it. So 29 plus 1 is 30, and HELP happens only in pregnancy. So that is 29:1. Okay, I hope that is clear. So that brings us to the last portion of our discussion, that is our systemic disorders with secondary thrombotic microangiopathy. Now, this is thrombotic microangiopathy. That is, there is evidence of on histology, there is evidence of thrombotic or microvascular thrombosis, but there may not be clinically evident microangiopathic hemolytic anemia. Okay, so one important consideration here is that hypertension can cause both microangiopathic hemolytic anemia and can be the result of microangiopathic hemolytic anemia. Okay, but obviously hypertension is a very common disease, and microangiopathic hemolytic anemia is much less, is a rare disease. So it is much more common for hypertension to cause microangiopathic hemolytic anemia rather than vice versa. Now, clinical features that suggest hypertension related MAHA over just MAHA are the patient profile, that is a patient who is a male older than 50 years 40 years of age, does not have a family history, has an antecedent history of chronic hypertension, has objective evidence of LVH, that indicates that there is long standing hypertension, and has history of recent cessation of antihypertensive agents which would result in sudden elevations in blood pressure. Okay, now there are two systemic autoimmune disorders that cause MAHA in two specific contexts. One is our scleroderma renal crisis, and the other is antiphospholipid antibody syndrome related microangiopathic hemolytic anemia. Okay, now scleroderma renal crisis obviously is an antibody mediated damage to the endothelium, which happens due to RNA polymerase 3 more than your topoisomerase 1 antibodies, some very rarely with 3 U3 RMP also. Okay, resulting in your arteriosclerosis. It is thrombosis of the afferent arterioles resulting, or the arcuate arterioles, resulting in very significant RAS activation and significant hypertension, and with microangiopathic hemolytic anemia on the biopsy. Okay, in the glomerulus. Now, obviously, there will be an association of there'll be the ANA will show a nuclear speckle pattern, and ENA, LIA, will show positivity for anti-RNA polymerase 3 and anti-polymerase 1. U3 RNP and also topoisomerase 1, but please remember that is that also happens. Now, the important thing is U3 RNP, although rare, has a high relative risk of developing scleroderma renal crisis in younger patients. So that is something that we need to remember. Okay. Now, in APLA, as we've already seen, we've got various antibodies that are there against the endothelium, which result in activation of endothelium, macrophage, and platelets, resulting in thrombotic microangiopathic hemolytic anemia. We'll be discussing this in detail in case of APLA, so I won't go into the details of it now. Okay. Now, sometimes when you've got a systemic sclerosis patient, you can have features of SLE, so particularly MCTD patients and overlap syndrome patients. And in that situation, the clinical presentation can overlap with lupus nephritis and with ANCA-associated vasculitis. And the thing is, the treatment protocols for all of these disorders are very different. So if you have any doubt, okay, regarding scleroderma renal crisis versus SLE lupus nephritis versus ANCA-associated vasculitis, always do a renal biopsy. Should not avoid renal biopsy in this situation. Okay. Uh, okay. Now, clinically, APLA can affect the kidneys in multiple ways, and we'll discuss that. Okay, but like I just said, APLA positivity usually correlates with biopsy showing features of thrombotic microangiopathy rather than frank microangiopathic hemolytic anemia. But I've just discussed, so there will be significant azotemia without significant thrombocytopenia. Okay. Now, there are some hematological disorders that develop thrombotic microangiopathy, but again, these are usually not associated with clinically evident microangiopathic hemolytic anemia. Okay, so these include myeloproliferative disorders, Poem syndrome, and sickle cell anemia. So there are three disorders, that is myeloproliferative syndrome, neoplasms, your Poem syndrome, which obviously is associated with plasma cell dyscrasias, and sickle cell anemia. Now, what is happening in myeloproliferative neoplasms? The neoplastic clone is producing vascular endothelial growth factor and platelet-derived growth factor. Similarly, in Poems, the plasma cell clone is producing vascular endothelial growth factor. Both cause endothelial activation and endothelial proliferation. In case of sickle cell anemia, there is occlusion of small blood vessels within the renal medulla, particularly because the pH is lower in the renal medulla and there is relatively lower partial pressure of oxygen, resulting in increased tendency for sickling. That results in glomerular hypertension, and because of this, there is secondary glomerulonephritis, microangiopathic hemolytic anemia. So, important clinical things that you need to remember regarding this is, in case of MPNs, there is usually a delay. So, once the disease is diagnosed, usually there is a latency of around 7.2 years before you develop microangiopathic hemolytic thrombotic microangiopathy, and it can be a side effect of JAK2 inhibitors as well as hydroxychloroquine. Okay, sorry, not hydroxychloroquine, your hydroxyurea rather. Okay, now in case of Poem syndrome, very importantly, often there is unilateral renal hypertrophy. Uh, that is usually due to unilateral contraction of one kidney rather than enlargement of the other kidney, but the other can also be the case. Now, the second most common presentation of Poem syndrome is proteinuria secondary to membranous GN, and the immunoglobulin subtype that you find is IgA, and this is can cause confusion obviously with IgA nephropathy. 95% of the light chains, obviously this being a, as we've discussed recently, this being a plasma cell dyscrasia related renal dysfunction, here it is lambda subtype like we get with amyloidosis. Okay, now in case of sickle cell anemia, the presentation is almost always proteinuria. Okay, that is why I've highlighted that there is glomerular endothelial phagocytosis of sickled RBCs resulting in membranous GA. So the more presentation is for proteinuria rather than microangiopathic hemolytic anemia, but the biopsy looks like thrombotic microangiopathic anemia. Okay, so if you got thrombotic microangiopathy with the patient who's clinically got significant proteinuria, one thing that should be considered is sickle cell anemia. The other, as we've just discussed, is antiphospholipid antibody syndrome. So that brings us to the end of this discussion. Thank you for listening, and I'll see you in the next discussion where we discuss the histopathological diagnosis of glomerulonephritis with or without presenting as nephritic syndrome, with or without significant nephrotic range proteinuria and thrombotic microangiopathy. So thank you, and I'll see you then.